I first saw Pat Masters online with this amazing picture she has that's like the best headshot ever, okay? It is, and she's just got so much presence. And then I started like Googling her, because I do that to people, and found her LinkedIn, and found her history, and the fact she was a reporter, and she's been in this space forever, and what happened to her that made her join this space. And I was like, what an amazing advocate. And I am so honored to introduce you to right now, the amazing Pat Masters.
Gee. You are so crazy. Well, ditto. Regina Holiday obviously hit the radar early on, not just for her incredible artwork, but for her blogging. That is, she's just as eloquent a writer as she is a painter. And I was just astonished when I saw how much she touched people. And in the world of what we do, that is the magic sauce, is touching people with our stories. And there will never be another Regina Holiday, but I'm so privileged to be here to learn from her and to learn from all of you. And I'm very excited to be here. And I have great news, because I have a really special guest that's going to come up in a little bit. And I'll tell you about that. I also have a prize. Don't you love prizes? I have a prize for the person who answers a question during this thing the right way. So, don't you love prizes? It's fun. Okay. Well, this obviously is the whole scenario that got us into this in the first place. It was the Partnership for Patients. And we patient advocates were, wow, that's pretty cool. We're going to have a partnership for patients. And we're kind of sitting there waiting to get phone calls and waiting to get invitations to go to events and to participate. And, you know, for those of us who've been in the trenches for a while, this is very exciting. So it took a while. You know, there were events where some advocates who were known to given hospitals might be invited to present. But you know, for the most part, maybe we were hard to find, but finally we were found. And that's the story that I'm going to get into. But first, you know, despite what Regina said, let me just share a little bit about who I am, why I'm here today, and then the story of how we got to be at a partnership with patients. So this is how I became a patient advocate, the same as the rest of you. Something fell upon us. You know, nobody would plan to have an adverse event in their family, their friends, or for themselves. And in my case, this was because my father, who was a healthy 75-year-old at the time, was mowing his lawn one day, and then he got up to use the bathroom at night the next day, and he fell down the stairs and ended up fracturing a vertebra in his neck and went into the hospital for surgery. And that went great. Wonderful surgeon. Everything went perfectly, and then 2 days later in the step-down ICU, his intestines ruptured. And they said, we have no idea why, just don't know why that happened. And I learned that it was C. diff. I learned that on my own, and it was in my pursuit of finding answers that I came to be, to use some of my background to, as you all do, identify the unique things that you have that you can bring to make something positive out of something so negative. So this is me. I was a medical reporter and a news reporter for more than 20 years. When this happened to my dad, I said, you know, people have to know this stuff. When I read that 100,000 people a year die of infections and they couldn't even pronounce them, let alone know what they were, I said, all right, I have to get this information out there, like so many of you. And you wait for people to find you, and you say, oh, as soon as they do, they'll be aware and engaged and empowered. And it doesn't quite work that way. So, but through the website, I found some people who came to me, because I'd been, you know, a big fish in a small pond on the news, and shared their stories with me. I said, oh my God, this is so hard to listen to. I mean, to this day, I can get breathless listening to the same stories that I've heard. And God forbid the news stories we continue to hear. So we passed 2 patient safety laws in our state, Rhode Island. One was an infection reporting law that is in 26 states now. And the other is to equip a patient at the bedside with a list of things to look out for, ways that you can partner effectively by, for instance, understanding not to touch a dirty bed rail because of the C. diff bacteria, to look for signs of infection because maybe your caregiver might not see it. And ultimately, we are the last person in that chain of people that harm has to penetrate for us to become a victim of medical harm. So it makes me crazy to think that a lot of the conversation is about, we have to do this for you. We have to protect you. We have to take care of you. No, you know what? I want to tell everybody, wake up yourself. Be part of the solution. And so my challenge is to engage the community. In the news business, I'm going to share a little secret with you. There are 3 things that always get attention. And this is a very well-known formula in the news business. There are one-syllable words, and it's pets, tots, and a piece of female anatomy that starts with a T. So those are the 3 things guaranteed to get attention. Now, we are so far from this instantly interesting topic. We are as far as you can get, unless maybe, you do algorithms for NASA or something. But it's very hard to engage the public. So I thought, I've spent so much time in that space where we literally are told to speak to a 3rd grade reading level. Never mind 5th grade, which is where they say health literacy is at, 3rd grade. So what are some of the ways that we can do something out of the box to get this conversation out of these wonderful spaces, which really are echo chambers, quite honestly. We all agree with each other. We want to fix things. And in the good hospitals, they too are in echo chambers. So how do we make sure people are talking about it in the airport and at the water cooler and in the train station and wherever they move around? So I started a YouTube station, and if you Google my name on YouTube, you'd see some vignettes I'm using, produced by young people, new college graduates, and they have produced 1.5-minute topical things that are, I think, pretty funny. They're all focused on the patient. The patient is 21, he's like a Borat, and he knows nothing about hand hygiene. He knows nothing about that doctors don't know everything, and he knows nothing about being a difficult patient. So the objective of those is to sort of introduce those topics. So if you have a chance, Google that, because this is one point I want to leave you with, and I'll touch on at the end as well. In 2005, there were 8 million hits on YouTube a day. That's when they started. Google bought YouTube in 2006, and today there are more than 4 billion hits a day. 4 billion hits on YouTube. And my question for the big prize that I'll give you shortly is, the one that comes closest without going over gets the prize. How many hours of content are uploaded every hour? How many hours of content? Anybody want to guess? 114,000? No. No Googling, no Googling, no Googling. Anybody? 2,000? Nope. Oh, 14,000. $78 million hours a day. An hour are uploaded to to YouTube, sorry. So we're going to have another question to get a prize. Are you looking up that now? Because I left my note, but I'm pretty sure it's 78 hours of content every hour is uploaded on YouTube. This is the direction that outreach has to go, people. And in your advocacy work, keep in mind people are getting lazier every day. They want you to show them. They do not want to read. And if your website is loaded with copy, and mine is way too loaded with copy myself, so I'm with you, you got to fix it. You got to find ways to deliver that message very succinctly and personally. And nothing does that like video. So I'm very gratified and grateful that Regina's provided an opportunity for us to all try our speaking. And I would suggest you maybe use that as your landing page video where you reach out to that person watching you like they're your best friend, and you invite them, entice them and invite them to explore further with you. That's what you do in an opening video. Invite them in the door of your home so you can help them. All right. Do I have to point this at something? Okay, this is something that I created because I wanted tools at the bedside. I'm going to talk about this in an Ignite talk later. My father's hearing aids were ruined. I had messages all over the room to help him, the staff understand that he couldn't hear. He had no hand hygiene in the bed, which is a problem all over in hospitals, so I created this device for the bedside that I will tell you about later. But what I love is the message clip, because that is something that a patient has no access to, consistently messaging their special need. I don't want to dwell on that. I wrote a book recently called If IKEA Designed Healthcare, 9 Ways It Would Partner with Patients. It's going to be published later this year, thanks to a crowdfunding endeavor where Regina and Dave DeBronkart and some of my dear friends helped. But if you think about the IKEA model of healthcare, the concept is that a one-stop website would help us learn, connect, and plan. You'd get tools for success when you walked in the door. Patients would have to roll up their sleeves and help. The entire value proposition of IKEA, which is a model that we can understand as consumers and as businesses or providers, is of a common value proposition where we all help toward a common goal. It's the with concept. So, this, however, is how I'm best known. I made Dave DeBronkart look like a passive patient in a YouTube video we did at the IHI conference in 2010. It's a quick little thing we did where he wasn't asking any questions and he was completely disengaged, so un-Dave, and I'm sorry he's not here to see it, but this was, we had fun doing this. Where am I supposed to point this is one thing I'm curious about. Keith? Where am I supposed to? Oh, there we go. All right, Orlando. 2010 is where I first got an idea of what I was in for. This is a small sample of acronyms that I came up with off the top of my head. Okay. And we should have a quiz of how many. Maybe we'll pick one and see who knows what it is. Let's pick an obscure one. What's the AAP? Hmm? Well, I can't hear you, but if you said it, I'm sure you're right. So you're going to win the prize, and you have a patient pod right here. So there you go. I'm not going to walk all the way back there, but there's your prize. I'll leave it here for you. Thank you. And by the way, the last few acronyms are the ones that most of us don't have at the end of our names when we're in meetings with medical personnel. We don't have that, and I'm on the HIA Advisory Reporting Committee in my state. Everybody around the table has 2 or 3 of those acronyms after their name, and I'm the only one without one. So that's how we tend to feel from the very outset. We're just not like the others. And then I met Regina at the IHI event. She painted at one of the sessions, and she was already such a presence there. And what she did, essentially, as we all went around and told a bit of our stories, is she painted what she heard and then spoke about it. And we're all like, wow, the energy just sort of like emanates from her. It's like just such a power. And because what she does is so visual, it cannot be forgotten, it cannot be ignored, it cannot be overlooked. And it's driven by such a passion. So even then, that's how I became fascinated by Regina, and we began to exchange emails and ended up, getting to know each other's work. So this was our first partnership for Patients Call, that Regina and I were online sharing emails with each other. And if you've read her blog, you know how that all came about. There were some technical problems, and first we were supposed to meet in person in Washington, D.C., and then there was no money, and here we were on this call, and I couldn't contribute. So Regina says to me, if you can see, jump in, and I said, I can't. I'm listening, but I can't technically speak. And so then there was a little bit of an attitude readjustment by Regina, who said, there are people on this call feeling managed, and you should apologize. And I'm like, oh my God, I so could never say that. I said, it's just so not me that I don't know if I thought they would hate us or the phone lines would erupt in flames. I have no idea. But I'm like, oh my God, she's saying this. And it broke a dam, and everybody started to share honestly how they felt. And here, instead of being hated or being marginalized or having the phone lines erupt in flames, we decided that with trumps for, in some ways, where we almost had another acronym here in the whole world of migrating toward a common ground. And the great thing was it was a turning point. And I want to say that what I've learned, and our special guest will join us in a moment to share more about this, but we all have to get to know each other. This whole movement is so new, and it's almost like when we are invited, we're like the new person coming to the family reunion where everybody's known each other for years. It's not that they intend to ever, do anything less than embrace us. They just often are still figuring it out for themselves. And so we need to give them the same gracious understanding of that and help them and teach them as they need to extend to us. So we've started to do some events. I was at the Partnership for Patients, a retreat 2 days ago at the invitation of our guest who's going to speak in a moment. And it was a very dynamic, interactive workshop where I got to see some of the challenges that they have. And they are incredibly well-meaning people. And I just teased them, I said, because this was our government at work. And I had this image of my head of a story we did in the news business years ago called Money for Nothing, where our secret cameras followed the state workers as they were supposed to be filling potholes and doing road repairs, and they were asleep, and they were at Dunkin' Donuts for 2 hours, and that was our government at work. Well, this was our government at work in a very collaborative and interesting and wonderful meeting, after which we took a picture. Oh, where is it? There we go. And there we are, Partnership with Patients. And you may see her, where is she? In the lovely blue dress, third from the left in the second row is our guest who's here today. And I was so proud that I actually knew how to take a little screenshot of her face, which is way too small. But here to talk about the intersection of the Partnership for Patients and Partnership with Patients is Teresa Titus Howard, who has all those acronyms and lots of titles, but is a wonderful person, and I was delighted to meet her, and I'm delighted she's here today to talk with us.
All righty. Thank you.
You want to go up?
Well, it is a great pleasure to be here, and thank you, Pat, for those nice comments. And it was wonderful to have her at our meeting on Thursday. So I am from, so sometimes the funny story is I'm here from the federal government, and I'm here to help you. So, that's not true. So basically, I am a federal employee. I do work for the Centers for Medicare and Medicaid Services. And what we, CMS, there's another great acronym for you. We are pretty much charged with the lion's share of implementing the Affordable Care Act. Obamacare, what most people call it, but I tend to want to call it the Affordable Care Act. And so we are been charged with that. And part of that is at the Innovation Center in the Center for Medicare and Medicaid Services, where the Partnership for Patients lies, its home. And I have a wonderful team and wonderful leaders that I work with that actually are implementing the Partnership for Patients on a daily basis in cooperation with the Partnership with Patients and Regina and all you all. But before I get into that, because actually I'm here officially but unofficially because of this silly season. And so I decided, and the silly season means what's going to happen in the next 5 weeks or so. And so, I was thinking about that. I was like, okay, on this side of my name tag, it says CMS, okay? But first, I'm gonna talk about this side of my name tag, and that's the patient side. And so I wanna tell you about my story, and I think it's really, really important. So I'm representing myself as a US citizen, private citizen, coming and sharing with you my story. So, and also, it really relates to the beautiful jacket that Regina painted for me. Thank you so much. In like 1 day, 2 days. When she heard I was coming, we talked on Monday. She goes, if you can get me a jacket by Thursday, I'll paint one for you. I was like, oh my gosh, what an honor. I was there that afternoon at her house, giving her my jacket. So, well, I'll show you in a minute, because I'm going to share my story first, and then the jacket will make more sense. Alrighty, so in my professional career, I actually started out as a clinical social worker. So patient advocacy, patient-centeredness, client-centeredness is so much of who I am and how, what I love to be on a daily basis. And so I actually started working with children with diabetes in a children's hospital. And then actually went on to work with actually a healthcare home health agency, and also had the wonderful opportunity to work with hospice patients and in the most critical time of their life for them and their families. So having that, so I was, I loved healthcare. Healthcare is dynamic. There's so much change, and I love change. I embrace change as a person. And so it was really a great fit for me in my professional career. And then in 1999, is when the whole idea of what it means to be a patient came full circle to me. I was actually went to go see my new OBGYN, and bless her soul, she did a complete head-to-toe exam, and she said, and she was kind of feeling my neck, right here. She goes, you need to get that checked out. There's just like this bump right here. She goes, I really think you need to go get that checked out. Okay. I'm like, okay, I'll do that. So I went and got it checked out. And I actually went to go see an endocrinologist. And what it was actually a nodule on my thyroid. And I very astutely remember when they were trying to officially diagnose it and try to determine whether or not they're having surgery, laying on the table like this with a needle coming at my neck like that to pull a biopsy to try to figure out what it was. And what I remember about that incident were the nurses. They were amazing. They knew I was scared, but they said, you know what, you have the most beautiful eyes. And so they really made you feel comfortable going through that whole process. So the initial results came back negative. I'm like, great. There's hot nodules and cold nodules, if you know anything about thyroid conditions. And so I was like, great, this is wonderful. But my endocrinologist, another very positive experience with my healthcare providers, said, you know what, you're too young. I was 30 at that time. He goes, I'm not taking a risk on that. We're going to have that removed. I'm like, okay, alrighty. So I went in for a complete thyroidectomy. So I have no thyroid, like you all do. It's gone. and so I actually live on thyroid supplements. That's my lifeline every day. And so the surgery went great. I had the most amazing nursing student, and actually, resident, who actually, I had a drain come here, and she was so calm and so touching and just very caring. But the news, so everything went well, went home, I was recovering, but the news came really to a head on December 18th, and that's when they said, well, we got the biopsy back, and it's cancer. Wow, huh? I'm only 30. There's no way it can be that. So needless to say, I didn't have a good day that day. So the course of treatment then, already had this surgery. And what had happened was that the cancer cells in the nodule, when they did the biopsy, they went straight in to the nodule and pulled out the biopsy from there. The cancer cells were actually underneath the crust of the nodule. So far, I am so grateful for my OBGYN, who said, go check that out, for my endocrinologist, who said, I'm not going to take a chance here. It needs to come out. And so grateful to both of them for saving my life. But the really interesting part in this experience, which is overall very positive, and that's what I'm getting at, that it was a very positive experience for me, was when I had to go in for treatment related to radioactive iodine. Now, remember the movie, The Boy in the Bubble? Who remembers that? Yeah, okay, good. So basically, what it looked like, in that room, they literally had to cover everything in the room because of the radioactive iodine that was being given to me. They had to cover the phone. They had to cover the TV. Anything that could be touched was covered. And I remember feeling really, really alone. I couldn't have family members come. I couldn't, and the nursing staff kind of, they're so helpful, but they just kind of peeked their head in. They knew I was okay. So it was a very, a great time to reflect and think, oh my gosh, I never thought I'd be in this situation. So So basically, the radioactive iodine was successful. I am here today, and things are going great. And so I regularly basically have to have my thyroid measured to see how it's doing. But other than that, I'm perfectly fine. I have a husband I've been married to for 23 years. I have 3 wonderful children, a 19-year-old daughter, 18-year-old son, and an 11-year-old son. So life's good. Life's really good. But at a very young age, I woke up pretty quickly and realized that the patient piece is so important for my own personal experience. And I kept that with me going along. I mean, yeah, I was a clinical social worker, and I worked with kids with diabetes and endocrine disorders, and worked with home health and hospice patients, but it just really became profound to me. And so over my career, it's been kind of interesting when you look back on your career and how things just kind of seem to happen and how your passions come all together. So it was interesting that I've actually worked in, so I was a patient, but it's what I call the 6 pillars of healthcare. I have the experience of being a patient myself, a very positive one and very grateful one. Actually working with patient-centered approach, working as a social worker with patients themselves. Also had the great privilege in working in a provider setting. So I understand the in and outs of providers and the challenges they face every day providing quality of care. And then I actually had the opportunity, I went to the dark side, and I actually worked for a health plan, the payers of healthcare. That's the next pillar. And had a great opportunity to work for Blue Cross and Blue Shield of Kansas City, actually here. And really was impressed by the individuals working there, where they were dedicated every single day to quality patient care for their members. Despite what you hear on the news, it was there. Their love and passion for quality of care was there. And then I had a wonderful opportunity to also work with employers who actually pay for health care as well. Another part of that payer pillar. And then about 5 years ago, I was working on my doctorate, and I decided to go work for Medicare. And little did I know that I really just kind of rounded it out a little bit, because now I'm the policy. I've got the policy knowledge as far as what policymakers are challenged with and concerned with. And they, too, have a very core, believe it or not, at their being, they want to do the right thing. So as a result of all those experiences coming together is why I pursued my doctorate in public-private partnerships. That's the 6th pillar. And so I love bringing stakeholders together. I love being able to, these types of events. I'm just on cloud 9 and I'm having chills right now talking to you. But it's a great, the ability to bring all of the stakeholders to the table, from patients, payers, providers, policymakers, all to the table, to understand what we need to do to lift and to improve this delivery system. So that's my passion. And so now you understand what my jacket means. So now this is a Toastmasters no, I'm sure. So turning my back on the audience. So you'll see, and Regina, she did it so beautifully. So, you see me in the forefront as the patient with my doctor and my 2 doctors, actually, that were just tremendous. But you'll see the stakeholders around the tent. They together have to work together to build a more effective delivery system. And so that's what that represents. And so now it makes a little more sense now that I've told now that I told my story. Okay. All right. So just wanted you to know that first, because I wanted you to know me. And yes, I do work for Medicare. Yes, I do work for the federal government. But I'm also me. And I also have a passion for patient advocacy and patient wellness and patient great quality of care as well. So I will just share with you a little bit about the Partnership for Patients then. Okay, so now going from this to this one, okay? So the Partnership for Patients is a result of the Affordable Care Act. So I think you all know about the Partnership for Patients, correct? People that don't know about the Partnership for Patients, I think you all know. Okay. So the Affordable Care Act actually put into place Section 3021, if you want to go read it, basically the establishment of the CMS Innovation Center. And under the leadership of Don Berwick, who is very sadly not with us anymore as our administrator, through his leadership, we actually implemented and established the Innovation Center. And it's literally a startup organization, looking at how we can do three things: improve the health of our population, improve the healthcare quality that people receive, and also how can we reduce cost through improvement. Very important two words on the end there. So at the Innovation Center, that is our true north every single day. Every single day. We focus on that, and the law is very prescriptive in some regards about some of the areas that we focus on. Are you familiar with Accountable Care Organization concept? ACOs? Okay, so ACO is in the law, and it basically wants to see that care is better coordinated for patients. So how many times have you maybe talked to your family physician, but you're also seeing a cardiologist, and maybe you're seeing an endocrinologist, and none of them talk to each other? Or maybe you had an inpatient hospital stay, but going out into the community to get your care, it's uncoordinated. So that's what ACOs are about. And so it's our commitment to test whether or not that really does meet that three-part aim: better health care, and lower cost. So that's one example. And it's very community, grassroots driven, okay? It's not Big Brother saying what you got to do. It's more very community driven. And then another piece of the law was related to the medical home concept, primary care. That primary care really is where it's at, related to that patient-physician relationship. And the primary care doctor really knows how, and that patient know together how to coordinate that care. So we also have, but what's interesting, one of the barriers that we encounter in primary care is that the payers tend not to want to work together. A little bit of competition. Okay, heart of America. So what is interesting about this model that we're testing is that we have 7 markets where we have all the health plans, all the payers of healthcare, working with the primary care providers and patients in healthcare, as well as Medicare. That doesn't happen at all. So it's an idea, wow, maybe we all need to come together in a partnership to work together to make sure and see how we can do this better, because we're not doing it right. We need to do it better. And then one last example I'll give to you before I get into the partnership for patients is related to bundled payment. So what I mean by that, currently right now, if you, for those of us who have had children, we know that with the OBGYN office, when you go through that whole process, that's kind of, that OBGYN receives one payment. And so it's bundled. So the idea is that how can we look at a bundled payment system where the hospital shares the risk, not only financially, but responsible for coordinating that care with an outpatient provider. They get a bundled payment together. Boy, incentives are different, and alignment becomes even more critical. So how am I doing on time?
Like 3 or 4 minutes?
3 or 4 minutes, okay. So those are just some examples. So the Partnership for Patients, I loved having Pat there because she's so, it's very true. We are very passionate every day. If you've met Dennis Wagner or Paul McGann, who are senior directors for the Partnership for Patients, they are just over the top, so enthusiastic, and it's wonderful to work with them. So the Partnership for Patients, what we're looking at is how can we reduce harm in hospitals. I want to go to a hospital, and I don't want to have fear of being harmed. So our goal, it's very big and bold, true to Dr. Berwick, that we want to reduce hospital-acquired conditions, C. diff, urinary tract infections, pressure ulcers, those are some examples, by 40% by the end of 2013. Now, in healthcare, that's really bold, very bold, where we typically like to see maybe 2%, 5% improvement. 40%. And then also we want to see a 20% reduction in readmission rates, like where the care is better coordinated for that patient, so they don't come back to the hospital within 30 days. And so that's kind of what the Partnership for Patients is all about. And so we have private sector partners, we have you all that we want to work with, we have our federal partners, and we also have the hospitals that we're working with. Over 4,000 hospitals have signed up for the Partnership for Patients and are involved in what we're doing. So, and then I'll give just one last example of some of the results, because we're very results driven. So one of the conditions we're looking at is early elective deliveries, where we want to reduce the number of babies born before 39 weeks. Because data shows that their lungs are not even fully developed. And so instead of it being a convenience for the doctor who's going on vacation, or a convenience for a mother who seems to be pretty persistent, it's really about making sure we do not deliver before 39 weeks. Across the country, hospitals are implementing what we call a hard stop, meaning that 39 weeks, no less, maybe more, but no less. And so we're seeing that being adopted. This is a great example of where we've got the patient voice in there. We've got all the 6 pillars of healthcare working together to make that happen. That's very, very exciting. And so we're seeing some excellent results about that around that area. So that's it. And I think I'm being yanked off. So, but yeah, so that's basically my personal story and what I love to do and get to do and very privileged to do on a daily basis. And so, and thank you for your time.
Okay, thank you. Thank you, Teresa. And I know Teresa will be around, and I know would love to talk with you folks and hear your thoughts. And I found a very wonderful reception when I was talking to the P4Ps or yeah, whatever. Right. So these are sort of some of the things as we go forward that we can't do anything about in life. You know, there are just some events that are bigger than any of us, and we would be ill-advised to spend time and energy fighting any of them. And there's one more. Talking about a force of nature, I think the fact that we're all here is testament to, you know, when you say you don't have any power and you're just one person, I think that you look this up in Wikipedia and you should see this picture. Because think about this, it was May 22nd of this year that we had that phone call, 4 months ago. And I asked Regina a minute ago, so you did all this in 4 months? She says, oh no, really, we just sat around for a couple weeks saying, you know, we gotta do something. So she did this in, 2.5 months, while she watched 2 children, painted, 7,000 jackets, and whatever else she's done. So this is a great takeaway for all of us, is to keep that in mind. And I'm gonna leave with you one thought. I began at the beginning of this event to talk about the house that fell on me, which was infection. That's my jacket. And when we talk about some of these things happening to us, as Regina points out in the blog post that explains this, she says, I ruffle my son's hair all the time. He says, Mom, I hate that. And she says, well, if I ever stop doing it, the pod people got me. And remember those movies, or some of you are old enough to remember, it was like people would go away and come back different. And you just didn't know quite how. And when something like this happens to you, how do you explain to people that have never experienced it that it can take over in a heartbeat and change your life forever? But I want to take this very negative word of infection and think about it as another definition, which is the ready communication of an emotion or attitude by contact or example, such as an infectious laugh, an infectious smile, an infectious idea. Now, what we saw yesterday was people leaving this building to go out in the community and do the best kind of infecting, which is to give people a little dose of an idea, of a message, of a thought, and let them take that message out there. And that's our opportunity here today. So I thank you all very much for your time, and I'm thrilled to be here, and I look forward to talking with you and learning from all the rest of you as well. Thank you.